Hi everyone, I'm happy to join you at Svesem to be presenting here. My name is Björn of Ugglas, and for the last 9 years I've been working at the Karolinska University Hospital and the Stockholm South Hospital, mainly with business and organizational and process development within emergency care. And for the last 5 years, 4 or 5 years, I've been working on my PhD thesis that I defended now in March, and I'm going to present some of the conclusions from that thesis and focusing on two areas, on two of the studies. So I'll share my screen here. So I'm going to talk about ED crowding and the lack of hospital beds and how that impacts patients. And as I said, I'm an engineering background, and now I defended my PhD thesis on on demand and capacity imbalances in the emergency department and how that impacts patients. And you can see here's the link to the thesis. If you want to look at the thesis, the 4 articles are also available on when you look for them, you search for emergency department and Björn of Ugglas, you should be able to find the 4 articles. So a bit of background on hospital beds. I think you know already that Sweden has very few hospital beds per inhabitants. And on this graph, you can see all of the OECD countries, so the main developed Western world type of countries, and how many beds they have in each country per 1,000 population. And you can see the development from year 2000 to 2018. So over here to the far end, at the lowest level of hospital beds per capita is Sweden at 2.1 per 1,000 people. And you see that we declined from around 3.5, 3.6 or something over the last 20 years. And as you can see here from basically all of the countries from in this group of countries, you can see that all of the countries except 2 or something have declined. They're using fewer and fewer hospital beds. So, and this is actually this is a fantastic development, and it's very positive, and it's made possible by medical innovations that reduce the need for inpatient care. We don't need as many hospital beds now that we did 20 years ago. We've got the development of laparoscopic surgery. We've got endovascular interventions for stroke, for surgery within the heart, and many different areas. And we have new diagnostic tools like high sensitivity troponins and other biomarkers that enable us to avoid long surveillance, diagnostics, and so on. So overall, these are examples of innovations that reduce the need for inpatient care, and that's fantastic. It's a much better use of the society's resources. The problem is when you reduce the number of beds quicker than you innovate. So if you just reduce the beds without coming up with a new way of reducing the need for inpatient cares, you have a problem, and that would mean that your bed occupancy would simply increase. And this is actually what we've seen in Sweden, where since 2001 we reduced from I said some 3.6. This is 3.5 in 2001. You see the number of beds going down to the 2.1 we are at today, almost. And at the same period, you can see that the hospital bed occupancy has increased quite radically from around 80%, so to up to over 95% here in 2017. So we see that we reduce the number of beds quicker than the demand is declining. So that's a bit of a problem. So how does that impact the ED? What happens there? Yeah, we've seen it's not too unexpected. We don't have a long time series here, but at least from 2010, we can see that the median length of stay in the Swedish EDs have increased by 51%. So from 148 minutes to 224 minutes now in 2019. So we see fewer beds, a higher bed occupancy, and more crowding in the EDs, or at least longer length of stay, which is a good marker of crowding. So, and there's no signs that these trends are reversing. So the question for my PhD thesis was then, how does how does it impact patients? And that's what we're gonna look at. So the research aims in the thesis were 3. So we were gonna investigate the hospital bed occupancy, crowding, and mortality. That's the outcome we're gonna study. And the first association that we're interested in is the association between the hospital bed occupancy and mortality. Is there a direct association between lack of hospital beds and mortality for the patients that seek care at the ED? If it's not a direct relationship, does it impact crowding, so to speak? Do you have increased levels of crowding when you have a lack of beds in the hospital? That's the second association that we looked at. And the third, is there an association between crowding and poor patient outcomes in terms of mortality? So we performed 4 studies. One study on the direct relationship between the hospital bed occupancy and mortality. 2 studies on the association between hospital bed occupancy and workload and crowding, and 2 studies on the association between crowding and mortality. And today I'm going to focus on the direct association between crowding and mortality, where we performed 2 studies that we published. And I'm going to stick with these 2 studies. So for these studies, the study setting and the data sources. The first study was in the Stockholm region, the capital region of Sweden, from 2012 to 2016. We have 7 different EDs. We have different types of EDs. We have university hospital EDs. We have large inner city EDs. We have 2 a little bit more rural, smaller EDs. One is privately run, the other ones are public EDs. So a little bit of a mix, but all in the same region. We gather data from all of these EDs and combine it with national registries to create a database that we analyzed. The second study we did, we wanted to look at a more broader range of EDs, and also we realized that we didn't need all of the detailed data that we had, so we were able to use the Swedish Emergency Registry, SVAR, to analyze ED visits from 14 EDs across Sweden. So in the Stockholm region, in Örebro region, where we only had one, the Örebro Hospital, University Hospital, and then we had the Östergötland and Skåne, where we had the best coverage. So this was the study setting for these studies. So we defined, how do you define crowding? Maybe we've already talked about that during the day, other lectures. The way we define crowding in our studies is like this. This is an example of 3 actual days. This is a weekend at the Huddinge University Hospital, Karolinska, from 2019 with actual numbers. And what we look at is the number of patients that is in the ED compared to what the normal case is at this time. So this means that and ED census, that's the number of patients present in the ED. So here you can see you have Thursday, Friday, and Saturday. You have the day, evening, and night shift. You can see here that we had at 0-100 during the Thursday, we had 30 patients, and at that time of the night at Huddinge, we'd usually have about 25 patients. So we had a little bit more there, 30, and then we follow. You can see that here during the evening shift during the Thursday, we saw a large inflow or a lack of outflow, and we saw that the number of patients went up to about 80, but normally we'd have around 55 at this time of the day. So this curve here shows what this usually is. You can see here it's a statistical model that calculates how much it usually is. So you can see here during the weekend we expect to have fewer, so the peak is lower in the weekend, and that's expected. and also the staffing is lower in the weekends, so that's also accounted for. So here you can see that there is a gap between the number of actual patients compared to what's normal. So here you'd expect some kind of crowding to be indicated, and here you have less than what's expected. So it's actually goes pretty quickly from Friday evening, where it's complete chaos, to just 24 hours later, where it's more of a normal situation. So what we do is we see that the workload can even out during a shift, so we want to measure each shift. So from this shift here, we measured the average number of patients present. So this shift here was 51, so from 30 here to somewhere around 70, so the average was 51, and the average expected was 39. So that means that our crowding exposure is 51, the number of patients, divided by 39, the number of expected patients. And that's 1.31. So that means we have 31% more patients than expected. And this would be categorized as a moderate level of crowding. And then here 1.49, that's a high level of crowding, and so on. So each of these observations for each of these shifts, each patient will come into one of these shifts. And most of the shifts here, up to 75% of the shifts, they are the reference category. So that's a normal situation in the ED. And when we come to the end of the distribution here, and the high level and the moderate level, we see that this is the worst 5%. So the 5% of the patients that are most exposed to this crowding metric, and that the threshold in this study was 42%. So there's 42% more than expected. And the moderate level of crowding is between 15 to 42% more than expected in the number of patients. So this is how we categorize the patients. And then we compare the mortality in this group and this group compared to the reference, which is the normal situation in the ED, up to 75% of the patients. So we're using a proportional hazards model, and we adjust for a lot of potential confounding. We adjust for the hospital, we account for seasonality, and I'm not going into, because due to time, I'm not going into the details of the model, but it's well described in the studies if you want to look closer into that, the methodology. So we had our three crowding categories, 0 to 75%, 75 to 95, and 95 to 100. So this was the high level of crowding. And what we saw here was that we had an adjusted relative risk of 1.08. So there was an 8% increase risk of mortality within 30 days with a 95% confidence interval of 3 to 14%. So there was an elevated risk for the patients that came in to shifts that were crowded. So this was very interesting. So we then moved on to the next study, where this was Stockholm 2012 to 16, and then we move on to the other regions 2015 to 19, some more recent data. And what we found there, again, Stockholm, we start with Stockholm. In the overall analysis, actually, this is not in this table, we didn't find any statistically significant association between mortality and or between crowding and mortality. And the reason for this is that it seems to be very different. There was a heterogeneous group of EDs, and it seems to be different by region. So in the Stockholm region, we got pretty much the same results again, but a bit stronger this time, because now we had, the estimate here was for all patients was 8%. For admitted patient, it was 11% increased risk. So it's very similar to the 8% we got in the first study. But here we also got a 6% increase that was statistically significant already in this moderate level. So it seems to have gotten worse in the later period, 2015 to 19. In Skåne, we didn't see any statistically significant results for all patients. We did find a significant association here for the admitted patients in the moderate category. but it was only one observation here. For Östergötland, we didn't see any association at all for all patients. So there were not really any signs of an association in Östergötland. And for Örebro, we didn't have enough observations. We only had the Örebro University Hospital, and we didn't have them for all of the time periods. So we didn't have enough observations basically to draw any conclusions. So this was what it looked like. So Stockholm, a bit worse than in the previous study. Skåne, some kind of mixed result or signal here. And Östergötland, there was no association at all. So what we were thinking, okay, what were the differences between the regions, and started to think, okay, Stockholm has larger EDs, or the other ones have more rural, or what is the difference between these hospitals and regions? And what we found that the most credible or most interesting difference between these regions is actually the average hospital bed occupancy during the study periods. So where we had the strongest results in Stockholm during this time period, we had an average hospital bed occupancy of 101%. And in the previous study where we had results that was significant, we had a hospital bed occupancy of 94%. In Skåne, where we had mixed results, we had a hospital bed occupancy of 92%. And in Östergötland, where we didn't have any results, we had 81%. So this is only 4 observations, right? But there was still some kind of trend here with no results with the low and the strongest results with the highest bed occupancy. So this was an interesting finding. So and what could this be? And the reasoning that we have here is that it seems plausible that this association between crowding and poor outcomes, it could be reinforced by a high hospital bed occupancy, or having a low hospital bed occupancy could protect actually from poor outcomes. So if you have a high level of ED crowding up here, but you have plenty of beds, you have a low hospital bed occupancy, which is more like in Östergötland, is more likely to have. So you'd have crowded EDs on and off, but the sick and complex patients that you have in the ED, it's pretty likely that you can admit those to one of the beds that you have in the hospital that's available, and you have sort of a safety valve here where you have a low hospital bed occupancy. And if you have a high hospital bed occupancy, which you also can have during certain times, but you have a low level of crowding, so the ED is running at normal workload, but you don't have any beds, that could also be fine. You don't have hospital beds, but your ED is running at normal workload, and I mean, there's no lack of competence and resources in this normal case, so there's no problem. You could handle a couple of these sick and complex patients in the ED. The problem arises when you have both high ED crowding and a high hospital bed occupancy, which means that you have patients that are in need of inpatient care, but they are treated in the ED, and they're not treated in a normal ED. They're treated in a crowded ED where there's lots of patients everywhere, and there's lots of things to do, and you need to prioritize. And at the same time, you have sick and complex patients that you're not able to admit to the ED. So it seems credible that this could be an interaction here. So, and this also, I updated my literature review for the thesis and found this article and the research from New Zealand with Jones from 2020. And they investigated a number of crowding measures to see which ones are most strongly related to increased mortality and risk. So, and what they found was that access block was the one with the strongest association between with mortality, and they defined access block as the share of patients with an admission decision that had a very long ED length of stay. So when there was a lot of patients with admission decision waiting to get in, so indicating both sort of a level of crowding and also a need to be admitted, but a lack of beds. that was the strongest indicator of crowding. So this hypothesis is supported by this research also. So I think it's a path forward to investigate further. So basically, my conclusions here is that the association between crowding and mortality and crowding and poor patient outcomes that leads to at this level of impact on patient safety, it varies by hospital. So it's not the law of nature that it also always has to be like this, that if you have a lot of patients in the ED, it's dangerous. It's not like a radioactive zone or contagious disease in the ED. It's actually a well functioning area in many places. But when you have crowding and combined with high bed occupancy, it could be dangerous. So, but the interesting thing is that since it's not universal, it may be avoidable. So that's really interesting. So what can we do to try and get to a level where we can eliminate this association? And as I said, there are signs that a high hospital bed occupancy may modify and reinforce the association between crowding and mortality, or the interaction goes the other way, so that a low bed occupancy can actually protect from the impact of crowding on mortality. So that's the conclusions from my research, and my recommendations or what I think should be done is that I think we need to discuss the unclear responsibility for ED crowding in the healthcare system. As you saw, the trends with higher bed occupancy, fewer beds, higher bed occupancy, more crowding in the ED, it's been going on now for 20 years or so. It's a slowly, a gradual development in the wrong direction. And the question, where does it end? And now we've been able to show that it's actually impacts patient safety and mortality. So, it does impact patient safety and patients already now. So when does this trend end? And I think an important part of this is that it's not really clear who is actually in charge of this, because there's so many actors in the system and an interaction here. So that's something that we need to discuss. We should also, as a more of an ED community, I think we should focus more on patient safety and less on service level and availability. It doesn't make sense to look at, what's the share of patients that we can complete within 4 hours, or what's the length of stay for the patients. They should be able to get in and out and get care quickly. It's not about quickly anymore in many of these countries, in many of these regions. It's about patient safety. So we need to measuring service level metrics, it gives you the impression that patient safety is fine. We're now we're doing the fine tuning here and trying to optimize service levels, and I don't think we're there anymore. Actually, I think we need to go back, focus on the patient safety, and get the worst crowding out of the way. Another recommendation is that I think that all EDs in Sweden should connect to the emergency registry, SVAR. I think it's a huge opportunity for us researchers to do more research in an easy way. Get access to a large number of data relevant for emergency care. It was great to work with SVAR already now, and we're getting more and more observations. And I think if everybody connects to SVAR, we can do fantastic research in Sweden. So we should really, as an ED, go back to your verksamhetschef and ask them, when do we connect to SVAR? Because it's a huge opportunity for research and improving the organizations and processes of emergency care in Sweden. And on research, I think it would be really interesting to more go into the mechanisms of this association. What happens. You need to do even more qualitative data around what happens to these patients, do journalgranskning and activities like this to really understand what happens to the people that die within 30 days of in a situation where the workload was really tough. and are they different from people that die when it wasn't high workload and so on, and trying to figure out what these mechanisms could be. And also to continue to study and do more intervention research to reduce crowding. If we do this, can we reduce the level of crowding, or the high workload protocols where we can see if they work and so on. So I think that's a really interesting area to continue the research also. So with that, I want to thank the team that's been with me. It's Martin Holzman and Therese Järv, who's been with me all the time during the thesis, and Thomas Andersson, our statistician also, and then Ulf Ekelund, Per Lindmarker, and Petter Ljungman. Petter Ljungman, you may not know, he's a cardiologist at Danderyd and work on environmental air pollution and things like this. That have been my co-authors in these studies. So thank you.